training and graduated in 1994. He obtained a master's degree in chemical pathology and public health, respectively. He bagged 2 postgraduate degrees in chemistry and management, teaching at higher education in 2014 and 2016. Dr. Salam Mujib completed a PhD in medical laboratory science from Mount Kenya University, that is in Thika, Kenya. He started work as a lecturer in the Department of Pathology, Islamic University in Uganda in 2014. He has previously worked in the Lagos State Ministry of Health and Lagos State Health Service Commission, Nigeria, between 2004 and 2014. He's a member of the Technology Association. Despite being a Nigerian, what a zeal for the laboratory fraternity. His research interests HIV and NCDs. He's happily married. I don't know why he did that. He's happily married to Dr. Rofiat Balaule Abdus, if I'm not mentioned rightly, and are blessed with beautiful children. Let's give glory to God for that and for him. And we welcome him to take us home. And I also want to implore Charlton Martina, are you in the house? Yes, you so keep yourself ready as soon as Salam finishes. Salam has 2 papers to present. There is a paper in biomedical markers, management as exposing factors of dementia among patients attending selected referrals to Kampala. There is also a paper in anemia, a new modifiable risk factor among people living with dementia in Uganda. Gentlemen, let's listen to Mr. Dr. Salam.
Thank you so much. Good morning. I'm happy to be here. I want to thank the organizers of this conference and treats. Issue of testing to the optimal level, particularly in the area of dementia. So I'm interested in finding biomarkers that we can easily use to predict the onset of dementia, as well for diabetes and hypertension. So we should be able to see if we do this test and the results come up like this, either high or low, we should be able to see we can link the results with dementia. Then what is my major aim of taking up study in dementia? I've started studying since 2014. That is about 7 years ago, and I did my first research in Nigeria. And majorly is about biomarker because I'm looking at how to put laboratory into focus in the diagnosis of dementia. So we be interested in dementia. But what is this dementia? At one point in our life, we must have found ourselves in a situation to remember why we find ourselves somewhere. Maybe you leave your living room, you go to your kitchen, and you say, what am I doing here? You try to remember, you couldn't remember. You might have your car somewhere in the morning, and in the evening, you are looking for your car. I'm just holding my car. Whereas you park it somewhere, you are looking for it somewhere else. The commonness is you have your phone in your hands, And they just give you, let me call my phone, I'm looking for my phone. Until when they call your phone and it's ringing in your hands. So those are the symptoms of dementia. But the good news is that if you can still remember, at the end of the day, you see a face, I see Mr. Aliko, I know this face. I meet him before. You are trying to remember. At the end of the day, before you leave, you remember. Then it's not dementia. Or if you cannot remember, at least you think about dementia. So dementia is not a disease condition. It's a group of disease conditions, and we are going to see the presentation. What are the diseases or the syndrome we can look at when we are having the syndrome? So, my first presentation is anemia, a new modifiable risk factor among people living with dementia in Uganda. There are some risk factors that have been modified, and we have seen that anemia is one of the major risk factors of dementia. Because anemia, as we are going to see because of the presentation, is the first test we do. We check on the hemoglobin. Whenever it is less than 11 grams per deciliter, then anemia is established. But when it is less than 7 grams per DL, then that one is severe anemia, which is common in the as we are going to see during the course of the presentation. So I have to use my slide. Somebody can help me move. Okay, back now. Yeah, when we talk of dementia as a preamble, it's a clinical syndrome that affects memory, thinking, behavior, and daily activity. We always think of memory loss. It's just one of the cognitive impairments in dementia. But it's not only memory loss. We have to have about 2 or 3 other cognitive areas that are impaired. And we have thinking, we have behavior, and inability to do what we do normally, our daily activity. So by the time all those ones are impaired, then we know we are dealing with dementia. We have other, as I explained 3 days ago, we have other conditions that might be mistaken for dementia. For example, let me use the delirium. That one is unlike dementia, although there is confusion. But that one takes few days before it can be resolved. Once we know the cause of the delirium, we can give medication and the condition will be removed. But for dementia, once it has started, it has started. If we don't take necessary measures, then the person will be on the condition for life. So dementia, once we are able to diagnose it, if it is diagnosed early and we know the risk factor that is involved, like we are looking at anemia now, we can mitigate against it and remove the condition. So when we are talking about anemia, majorly we know it has to do with nutritional deficiency. We can have iron deficiency anemia. We can have vitamin B12 and folate deficiency. So once we link our dementia cause to these deficiencies, we can modify the risk and therefore remove the condition that is presenting with dementia. So when you give iron supplement of folate or vitamin B12, then the kind of food we eat, like I was trying to give us the background during my talk 3 days ago, most of the food we eat are deficient in nutrients that can help us prevent anemia. That's why what we give small children, mostly in Uganda, we say, mostly they say children don't need fish, they don't need meat. Even some people will say if they give them meat or fish, they'll be stealing when they become adults. Just the lies adult small children in order to protect their inadequacy in their ability to provide for the children. So anemia is a condition described by hemoglobin level less than 11 grams per day. There are many causes of anemia, as you know. Actually, among the elderly, we are years. We will see that our thirst and hunger area in our brain are affected. At times we don't feel thirsty, we don't feel hungry again. That is one of the major findings among the elderly. Then there are some conditions when we will not be able to swallow food. At times we even forget to take our food because we are busy with daily routines. So all this one, at the end of the day, we are going to have low level of hemoglobin, which is anemia. Anemia and low hemoglobin levels were shown to be possible risk factors for dementia. There are many studies that have established that relationship between anemia and dementia. I'd like to tell us that most of the studies we put, all the suggestions we have, are majorly from the Western world. We don't have much study done in Sub-Saharan Africa and particularly in Uganda. That one stimulated my interest that, okay, let us see what is here. Because there are many lifestyle changes in the Western world that are not obtainable in Uganda. Then the kind of nutrition we have in the Western world are not the one we have in Uganda. There are many other conditions that are not the same as what is obtainable there. So you cannot be citing and quoting literature from the developing world or developed world and now be comparing it to what we have here. So we still have issue of diagnosis. So I started with the routine test we do that is common, that is available. And let us see what we have on ground before we even think of what is not available. So our test, the hematology parameters we use for this study, they are the routine tests that are available. We can do them manually, and we can also use our hematological analyzer to do them. They are our normal CBC. They are what we check in the patients because we know most health center 3 can do hemoglobin. There are some strip for hemoglobin tests. There are some machines that deal with only hemoglobin. Then we can also use our manual methods to check for hemoglobin. And in some centers where we have advanced technology, you can use CBC. So major interest is to be able to look at the blood of the patient and see if the hemoglobin level is low. Then when the hemoglobin level is low, we can now look at other parameters. You can look at the MCV, MCH, MCHC. And the value there will guide us to know if what we have is microcytic hypochromic anemia or macrocytic polychromic anemia. So we can now know what is deficient. Is it the iron or is it vitamin B12 or folate that are deficient? Then why we should be interested is that many patients are undiagnosed. People don't have money for tests. Most doctors don't know the test to even request. When somebody comes to the hospital and we are suspecting the cause of dementia,
Let us.
First, you should remember, most patients are not brought to the hospital because of stigmatization. We see dementia as a punishment for everybody has done some sin, they are sinful, and God is punishing them. Then some people also look at them, maybe their wishes. Because from our study we see that we have many patients who are mostly women for obvious reasons. Women live up to 70 years and above. Most men don't live up to that age. And we have many ladies compared to landlords. And we see that women, they have better health-seeking behavior than men. So from our study we see we have many women who are participating, and the children prefer to take their mothers to the hospital. So all those factors really affected the selection of our participants in the study. So apart from those barriers, most health workers still don't know the test to do whenever they are suspecting a case of dementia. Then also, that is our conceptual framework. We told that she will go from the diagnostic. So let me just go to let me to look at to assess some hematological profile as possible diagnostic biomarkers of anemia in dementia among patients in Uganda, and the hematological profile we use as CBC. And when you look at the component of CBC, you have hemoglobin, you have PCV, we have red blood cell total counts, we have WBC total counts, what we call absolute counts, we have the differential counts, the neutrophil, eosinophil, basophil, monocytes. Then we look at NCB, that is mean cell volume, mean cell hemoglobin, mean cell hemoglobin concentration. We look at the platelets and the absolute platelet counts, platelet rates, which gives us the percentage. And also we look at MPV, that is mean platelet volume, and platelet regional width.
Sorry, doctors, Jill, been rightly informed that the commissioner is very much interested in your study and she's watching online. So the request is that you present all that you have in detail. So currently before us we have the slide on conceptual framework. So probably you'll be presenting as well while taking your eye to projection so that you get all right. Over to you.
So looking at the conceptual framework, the independent variables, we look at the then we look at the biomarkers, we also look at the risk factors. All of them, we now link them to our dependent variable, which is dementia. Now when we talk of dementia, as I told you, there are many different types. So we have those that are caused by infectious diseases. I've removed them from here because they are outside the scope of this presentation. But we really did the study on infectious diseases, particularly the bacteria that are involved in the cause of dementia. We also look at HIV and syphilis. That one will be presented in another study. So we have Alzheimer's disease, which is the major cause of dementia, is attributed to about 65% of causes. Then we have vascular dementia, those with stroke and cardiovascular disease. So They are the major risk factors for vascular dementia. And we have risk dementia. We have not been able to categorically separate this dementia. That's why I'm using the broad word dementia. We don't have the facility in Uganda to clearly differentiate and confidently say that this is Alzheimer's disease or vascular disease, and they are overlapping areas which are not clearly seen. So that is why we have what is called mixed dementia, because they are presenting, we cannot clearly differentiate. So in some patients we have Alzheimer's disease, in some we have vascular dementia. And when we have the two conditions in a particular patient, they are called mixed dementia. So there are other conditions too which I may not be able to say. We have many. We have big disease, we have frontotemporal lobe degeneration. There are many of them. Well, it might also interest us that vitamin B12 deficiency is one of the major causes of dementia and deficiency. Then we have alcohol-related dementia, we have drug abuse. There are some drugs that have been implicated in the cause of dementia. Then we have traumatic head injury. Then we have other causes like when we have trauma, like people who are boxers or people who accidentally hit their head against hard objects. All these ones have been established to be causes of dementia. The problem, the prevalence and effect of dementia on individuals, their loved one and communities are substantial worldwide. And when a patient comes down with dementia, it's not only that patient, it will affect the whole family. Because dementia is the last stage. You can have something like mild cognitive impairment when somebody is just forgetting, is just forgetful. We used to confuse normal aging. In normal aging, we tend to be forgetful. But when it has become mild cognitive impairment, which is the earliest stage of dementia, the frequency of that forgetfulness is more in what we see in normal aging. Then it is not stable by the friends and the relatives and the family. So by that time, that we start to notice it, then it has become a problem. So normally you can be forgetful and people will not know. There was a case of a woman, the man was having dementia, but the family didn't know until 3 years after. What really happened was that whenever the man forgets something, the wife will remind him. If you ask the wife, where is my phone? The wife can quickly say, this is your phone there. Where is my the car key? The wife can always show him. But when the wife died, that was when the children now started to know that this man had been demented since the past 3 years. So many of us too might have been finding ourselves in that situation in one way or the other. But if we have people that are reminding us, so it might not be manifesting. But at the stage when it's no more eating, everybody now knows that this man forgetting so much. We have our friends that we joke with, that say, you forget too much. So I think it's a joking matter, but it should be a serious concern for us because the person might be dealing with dementia. Then why we should be concerned is that if we all live long enough, all of us are likely to be demented. And the purpose of this presentation is to see how best we can prevent falling into victim of being a dementia patient. Then how can we diagnose it early so that we can seek help where it's necessary? The prevalence in East Africa is 5 to 23%, which we see is very high, and among the aged who are 50 to 70 years old. We used to think that dementia happens at 60 or 65, but because of many lifestyle changes, many things that we used to do at old age, we now started to do them earlier now. Then there are some disease conditions that used to happen maybe among the rich people or among the old people, like stroke and hypertension. We used to think it's old people's disease condition, but now we see that they happen even among the younger generation. That's why even when we are conducting this study, we have to lower the age of participant to 50 years. And as we are going to see in the results, the result is so alarming that as early as 50 years or 45 years, people are coming down with dementia. So the projection by WHO is that by 2050, the number of people that be affected with dementia will increase by 357%. And in Uganda currently, we have 1,243 people living with dementia. That was as of 2021. This 2025, 5 years after. So dementia is not an active area of study. That is why I want to encourage many people to be interested to take up research in this area. The last one we had is 2021, and as at that time there were 1,214 people living with dementia. Then we said, according to what we had since we started the conference, Uganda is a young due to increase in better healthcare facilities, and also infectious disease are being controlled. We have drugs medication that are being to people who are infected in one way or the other. So it's prolonging their life. The major challenge we have is these NCDs, and that's why this conference is speaking to NCD. Then there is rising population growth, which causes dementia. That was as of 2015 in the study conducted by Mamuli in Uganda here. So many people living with dementia remain undiagnosed. As I said earlier on, we have many people in the community who are not being brought out because of stigmatization, because people are even stigmatizing not only the patients, but also the family. If we say this is the family of the wish, then why do women, why the condition affects women mostly? Because we said they are the ones that live up to the extreme age of 80 years and above, because they have more better health-seeking behavior. So, what is the opinion for this study? We lack data. As I told you, I can say that dementia is a neglected NDC because most people, as we have been talking since 3 days ago, we are emphasizing most of cancers. Whereas all of us should be interested in dementia. One, we have old grandparents. If we don't have those ones, we have the parents who are old. And if we have lost our parents, we are all aspiring to become old. All the efforts we are struggling to make, all the money we are making, we want to live old, to enjoy the fruit of our labor. So it means if we grow so old and without having interest in what can we do to prevent coming down with dementia, all our efforts might go into waste. Imagine you keep your money in the bank, and at old age, maybe 55, 60, you know you have money, but you don't know the name of the bank. You cannot go to the bank.
Dr. Mjid, you have exactly 4 minutes to wind up.
So, that is why we should be concerned. Another sad aspect is when somebody has come with dementia, you will not be able to remember his loved one or her loved one. You'll be seeing your wife, you don't remember that you are even married. You see your children, you don't even know that you have had children. So it's as bad as that. So we can prevent all this and how we can help solve the problem. So let's quickly look at our findings. So these are the findings from the study. When we analyze the blood for hemoglobin level, hematocrit, the red blood cell, MCV, MCH, MCHC are all low, which is anemia. They are the indicator of the indices for anemia. When the hematocrit level is low, PCV is low, red blood cell total count is low. So this is in dementia. So it means that if somebody is anemic and is old, there is possibility of that condition predisposing the person to come down with dementia. That is the interpretation of the result. So in normal old age, if we have old people that are not eating, they have difficulty swallowing, and their blood level is becoming low. Yesterday they told us newborn baby have very high hemoglobin, but old people now are having very low hemoglobin. Once it's now becoming alarmingly low, lower than 11% or some, as low as 7%, then we know that this agent is likely to go down and become demented. That is the indication of the study. We also have very low value in lymphocytes and granulocytes, which is telling us that the patient can also be susceptible to having infection. And we have said that some infections are also disposing patient to dementia. So however, the total WBC level, there's no difference between the patients and the control. These are just the table showing the result as we see on the table. The hemoglobin level is low, is low. Dementia. The other aspect of it, we have the platelets and the platelet creams and the MPV. When the platelet is high, you know there might be clotting. When you have high platelet level, so there might be clotting. And when there is clotting, it can go to the brain and it can affect the brain. So high platelet level is also possibility of coming down with dementia. This is our logistic regression outputs. We see that there is co-linearity and multilinearity, which means even the presence of one of these factors can predispose to dementia. Meaning that if it's only the hemoglobin level that is low, it's enough to cause dementia. Or if it's only the red blood cell that is low, the total of red blood cell. If it is the MCV that is low, if it is FCA that is low, I think those who are medically informed, they understand this term. What we are saying is that even though just single hematological factor is enough for us to make a diagnosis of dementia, whether it's old dementia. So I'm trying to explain the implication of this finding, and the finding is also it has been established in some other studies. It's not only in our studies, so our findings are is in agreement with what has been found in other studies. A lot of people that are online, we have some conclusions and recommendations. So our conclusion is that very low value of hemoglobin concentration, red blood cell count, hematocrit, MCV, MCH, and MCC are suggestive of anemia in demented patients. And based on the results obtained, decreased erythrocytes and RBC disease, surge in leukocytes and platelet counts may be possibly involved in the pathogenesis of dementia. We have a question for the clinicians and also for the policymakers. As we are looking at any patient presenting with cardiovascular disease, it can be established that the risk factors for cardiovascular disease is the same risk factor for dementia. So the clinicians should also be looking at old people as they are looking towards the cardiovascular condition. They should also be thinking of dementia because they have been linked in the risk factors. So clinicians should consider recommending these hematological biomarkers during routine laboratory tests while attending to suspected dementia cases. So they should be looking at the results and thinking about dementia. Clinicians also should improve identification and diagnosis of dementia through these blood biomarkers during routine dementia evaluation. For the policymakers, the Ministry of Education and Sports and the Ministry of Health should help to suggest to maybe the presidency to increase the budgetary allocation for NCDs, and also dementia should also be included. Policymakers should highlight the need for urgent prioritization of dementia prevention, reduction of economic burden. So the finding from our study has the potential to impact policy and budgetary allocation in the midst of education and sports and also midst of health, and to create awareness about the burden of dementia in the people living with it, their family and the caregiver. Of the interest of time, this is what I'll be able to present. Thank you so much for.
Wow, thank you so much, Dr. Rajib. Let's give him a better round of applause. I'm very much interested and happy about what he has presented, and before you know it, dementia can be in your surrounding. Just to what he said, I had one of the colleagues in the healthcare industry. He's in his senior age. In Uganda, when you reach active service, they call you a veteran, senior citizen. So he went to one of the banking areas. I wanted to transact with his car, he parked there. And shortly after transacting, he walked out. But he forgot that he parked the car there. He went with the keys back to his home. So when he reached there, it was not until at around 6 p.m. from 10 a.m. that he realized the car was missing. So he was asking everyone, I don't know where my car is. Then they asked him, where did you go? Which areas did you pass through? He said, I only remember going to the bank. And on my way back, I don't know where I parked the car. So eventually, they had to escort him up to the banking area, and they found the car parked there from 10 a.m. up to 6 p.m. That is dementia. And he was at his early 60s. So this directly communicates to us as healthcare providers, our doctors in the house, with what Dr. Salam has presented, that we have to pay interest in these kind of biomarkers. I see Dr. Mujib, you've presented mainly, hematological indices, CPC as being a major test that should be prioritized in ambulance cases. Ladies and gentlemen, let's thank Dr. Mujib once again. Just to remind you that our theme is a very unique one. It says united by unique, placing people at the center of care. A very nice one. Yeah? So in that regard, I want us to ponder through whatever is being presented and know that dementia, we can all be candidates of dementia. Yeah? There is our tea behind there, and we will not have time to break off for tea. So So I'm announcing to you that it's going to be working team. So as we continue, just walk behind one at a time and pick a cup of tea, come back and sit. The tea is prayed for. The Lord has blessed it. So enjoy. We're going to, of course, take note of the questions. I am sure Dr. Jeep is going to attract a lot of questions. So colleagues, prepare your questions. We'll go to question session. But at this point, allow me invite the next presenter and the editorial team. I hope you set for Carlton Natinda. Carlton, it has been preferred that let Dr. present both his two papers. The paper is biochemical biomarkers, rearrangements as predisposing factors of dementia among patients attending selected referral hospitals in Kampala. So let's welcome Dr. Mujib once again for the second round. You have exactly 8 minutes, sir.
We are not going to present the results now.
All right.
You have the background.
Yes.
Nze mba siina kyendaba eno.
Kati eri
Eriwo. No, eno yali yagisindika mu gundi mu emebe
Yes, thank you so much. Good morning once again. So this aspect is looking at the biomedical parameters. There are many biomedical parameters, but I'm presenting only our routine biomedical tests, which are still affordable, accessible, and available in most of our health centers. So the biochemical parameters we are going to talk to are lipid profile, cardiac biomarkers, liver enzymes, troponin, cortisol, which is stress hormone. So those are the common ones which we know. There are other biochemical biomarkers which are at the advanced stage and are not yet available in Uganda. We have what we call SOD and catalysts which have been used, and we have MDA. So SOD is peroxide diamorphase. It has been established that we can use to assess the oxidative stress. There are oxidative stress biomarkers, likewise catalysts, but the reference is not. Okay, let me leave the background alone. Let me just go to our findings because most of the background have been given in the hematology. So I forgot to mention that we carry out this study in Uganda. We are using 5 hospitals. We use Mulago, we use Shiroko, these are national referral hospitals, and we use Lubanga when Igbo and Zambia hospitals for our cases and for our controls. We have a total of 156 participants that took part in the study, and it is hospital-based study. Mention is that we carry out the study also in the community, because many people don't come to the hospital because of stigmatization, except the condition has become maybe towards the end stage of life, they are forced to bring the patient out. So let's go to the results, please. Okay. So the finding from the biochemical biomarkers reveals significant difference when we take our sperm level to be less than 7.05 in triglycerides, LDL, that is low density lipoprotein, HDL, total cholesterol, ALT, AST, troponin, and cortisol. All of them are significant when we compare the cases with the controls. And when we say they are significant, it means we have high level of all these parameters. And as I said earlier on, the risk factors for cardiovascular disease in many of the literatures we research and read have been established to be the same risk factors for dementia. So when our doctors are looking at all these biochemical profile in maybe a stroke patient or patient with hypertension, so we should have it at the back of their mind that this patient too might likely come down with dementia if they were not treated. So these parameters are useful for early diagnosis. As I said earlier on, as we have in blood sugar and hypertension, when you have a blood sugar and maybe at two different occasions you have sugar levels that are higher than 120 milligram per dl or 7 millimole per liter. Fasting sample at two different times, that one is already suggestive of diabetes. So we are looking at the condition also. We have such parameters also. That, okay, when this level is higher than this value, we can think of dementia. Or when it is lower, because there are some conditions that we have low levels, and that is what is indicative of the possibility of dementia. Like in our study now, the HDL and the VLDL are very low in dementia patients. So we'll be thinking of low level for HDL and LDL. Whereas for high levels, when you have high triglycerides value, we have high LDL, we have high cortisol level, high troponin level. So those ones are high and they are there in the cases but not there in the controls. Then there are also increase in the mean value of the triglycerides, total cholesterol, LDL, ALT, that is alanine, transaminase, CK and CKM, the creatine kinase, and troponin and cortisol between the cases and the control. They are higher in the cases but low in the control subjects. But there is a decreased value in HDL and VLDL. So that is the table, the one we have in asterisks and in bold. They are showing us the values that are significant. Now we see triglyceride as I've mentioned and other values. But for VLDL, that one is not significant as we see here. So also our aspartate transaminase. Our possibility of diagnosis of dementia. Yeah, this one I did in the first slide. This is our social demographic study of participants. What I can generally say is that we look at the gender, at the multivariate analysis. What the results show is that it doesn't matter whether you are a male or you are a female. Demented. That is the addition of finding. So it's not difficult significant between the sexes. Either the male or female can still have dementia. Distribution also with our low age which is 50 to 59, we see that it doesn't matter also. As young as 50 years or as old as 50 years, somebody can have dementia based on all other factors that we put into place. But when we go to education, we see that education is significant, particularly when you have higher education. When you are using your brain so well and so much, you have seen many books and you have read many books, so you are not likely to have dementia. And that one we also lead to other conditions whereby we have to tax our brain. We should use our brain for thinking. I mentioned 3 days ago, most time now we don't think, we don't use our brain. We don't want any stress for our brain. Give a very easy task. You want to add money, you have to use calculator. Any slight thing you use a calculator. Whereas you have to task our brain so that the brain will not atrophy. Then also we play some games. There are some challenging games which we can be playing that we tasking our brain. There are all the activities that we make our brain active. Reading, writing. So we should be engaged in all to make our brain active. So we have seen that high educational level is very significant. Marital status doesn't matter whether you are married at 50 or not. It doesn't stop from having dementia. Then religion, we have 5 types of religion we use. Classified to Muslim, Christian, Pentecostal. We have other religion, national religion, but from our study, all members of different religions, they have dementia. So religion doesn't confer any protection. The residents that live in rural areas, slum or urban also doesn't confer any protection. But another thing we see among the social demographic is living with relatives and family. That one is very significant. So no matter what, try to live with somebody. There is this empty nest syndrome that is happening now, where you send your family away. Maybe you are living alone. Like I'm in Uganda, my family is in Nigeria. So that is a risk factor for me. If anything should happen to me, I'm really going to quickly call upon. Then when you are living with people, there are people that should make you happy. Not just living with anybody, you avoid violent relationship. So you make sure people that you are living with are the people that make you happy. So we have seen that living with people, relatives or family, is a protective factor. You can use that word against them. We try. We encourage family life. If we are married, we should remain married and happily married. Because my friend was asking me why I put happily married there. So we are married. Then if you are single, try to be married. Then we see social activities also is a factor. When you live with your family, it's a form of social life. You attend community meeting, you attend social meeting. All those ones we protect against having dementia. So from this current study, we see that the biomarkers we mentioned, the biochemical biomarkers, they are significantly significant. And the question is that high LDL is associated with Alzheimer's disease. and ischemic stroke. Then high lipid concentration, especially triglyceride and total cholesterol, is a strong risk factor for cognitive decline. High lipids, like high triglyceride and total cholesterol, they are strong risk factors for cognitive decline and dementia. So when we have significant decreased value in HDL and HDL, those ones who can be attributed to coming down with dementia. So for low HDL level, it is linked with poor brain health due to arterial plaque, damage to the blood-brain barrier, and cerebral arteries thrombosis. So the low HDL, we always talk of low HDL in cardiovascular disease condition, but now we are putting biomarkers which can also help us in the diagnosis of dementia. Then dyslipidemia is considered an important risk factor also for cognitive impairment. We talk about the food we eat. 3 days ago I mentioned Mediterranean diet. As we know, all these high cholesterol, saturated fats, they are attributed to cardiovascular disease. But for Mediterranean diet, we have the major components and the minor component of Mediterranean diet. You have to eat low quantity of meat and dairy products. Those are minor components. You reduce your carbohydrate intake, your meat intake, and dairy products. But for the major component of the Mediterranean diet, you take much more fruits, vegetables, legumes, nuts, granules, or peanuts, or any kind of nuts. Then olive oil. Then you look for food rich in vitamin C, particularly oranges. So those ones make up the Mediterranean diet. And I explained that it doesn't need us to go to the Mediterranean Sea to get Mediterranean diet. The food we are being served in conferences, we look at it, we see that they are richer in carbohydrates. We have kosho, we have matoke, we have rice. They still put chapati there. All those ones are carbohydrates. So we should reduce the carbohydrate intake. We have more of fruits and vegetables, more of. My sister was complaining about the food given to the fruits, very small banana. So I can improve on the food components. So this area is also considered an important risk factor. And this is not only found in our study, we have other studies that support our findings. So in conclusion, based on the results obtained, lipid deregulations, increased troponin, T and cortisol level, cardiac and liver enzyme surge may be possibly involved in the pathogenesis of dementia. So the work is still ongoing. The study on the common routine biochemical biomarkers, other biomarkers which we are still studying, and by the time you have the findings, you have to come to present them. So the same recommendation I've given earlier, we are also contained for our clinicians, for our stakeholders. Thank you so much for your patience and for your attention. Thank you.
Thank you, Dr. Jim, once again. The biomarkers have been understood properly to do with dementia. I hope you're free from dementia yourself. All right. So this gives us information and indeed light on the kind of tests that we need to prioritize when it comes to diagnosis of dementia in our people and ourselves. Ladies and gentlemen, I'm happy the house is growing. Dr. Annette, we are happy to see you, the chair of the Secretariat African Test and Treat Initiative. Allow me to take this opportunity to recognize the presence of Dr. Najuka Grace, Director, National Microbiology Reference Lab in Uganda. Dr. Najuka, you're welcome. Let's clap for her. Where's Dr. Najuka? Oh yeah, she's there. Let's clap for her. Very simple and professional. We also have Dr. Baizi Ajibad. Dr. Baizi is in the house. Great. Thank you. And we have Dr. Oburu F. Robert. Oburu. Is in the house? Okay, thank you so much. So, ladies and gentlemen, as you enjoy the break tea, it's working tea, we will continue with our presentations. And here, next presenter we have coming forward is Carlton Natinda. Carlton is going to present something that is quite interesting. It's to do with ethnobotany. Ethnobotany, this is interesting. Floristic and phytochemical studies of medicinal plants used to treat uterine fibroids in Mbarara City, in Uganda. Ladies and gentlemen, Dr. Natinda Carlton is a Ugandan pharmacist with a bachelor's degree in pharmacy from Mbarara University of Science and Technology and holds a certificate in clinical trials. Pharmacy practice and supply chain management prepared by the Ministry of Health. He is passionate about research, innovation, herbal medicine, and entrepreneurship. Wow, he's also an entrepreneur. He is a production officer at Abacus Parenteral Drug Limited. Carlton is currently developing a Fibrodex herbal, a natural remedy for uterine fibroids, and is committed to bridging the gap between traditional herbal knowledge and modern pharmaceutical science to improve health outcomes in Uganda. Ladies and gentlemen, that is Carlton. Welcome. He's going to take us on that presentation, and you have exactly 10 minutes, sir. Welcome.
It's a PDF.
Good morning, everyone.
It's a PDF.
As said earlier, our research is called ethnobotany, holistic and phytochemical studies of medicinal plants to treat uterine fibroids in Mbarara City. Next slide. So, I'm going to talk about the NCP, which is increasing at an exponential rate, more than any other NCP. This is called uterine fibroids. It is the most common gynecological tumor among menopause women, and less than 1% turns into cancer. So, globally, uterine fibroids affect 80% of black women and 70% of white women. In Uganda, the prevalence is estimated at 20%, and it is 28.2% in southwestern Uganda. High-risk factors include blood race, obesity, uterine infections, vitamin D deficiencies, and history of family history of uterine fibroids. And one of the major symptoms about uterine fibroids include heavy menstrual bleeding and intense lower back pain and pelvic pain. So currently, uterine fibroids is being managed by surgical interventions like hysterectomy, non-surgical interventions, and oral medication. There are several studies which have cited the medicines to treat uterine fibroids in Uganda. However, there is limited documentation. So our study was to investigate the traditional use and phytochemical composition of the medicinal plants that we identified. The specific objective included assessing awareness and knowledge of traditional medicine practitioners about uterine fibroids, then identifying and documenting the medicinal plants that treat uterine fibroids, and then doing screening for phytochemical groups that have the potential to treat uterine fibroids in these plants. So the study was done in Borough City, as you see. It was a cross-sectional study mixed with experimental design. And the study population was the traditional medicinal practitioners 18 and above. So it was snow. In the study, we used snowballing and capacitive sampling and identified 26 participants in the study. Semi-structured questionnaires were administered after informed consent. A variety of specimens were prepared, and these medicinal plants were identified and authenticated by the mass importance. In fact, the clinical screening was also done on the 8 selected plants based on the efficacy of citation in the study. So, in our results, which are the most practical, majority of the participants were female, as you see about 76% were female. The predominant age group was 61-70, and you see it is 30.8%, showing unwillingness of the older generation to train the younger generation about herbal medicine. And coming to the level of education, majority of the TMPs stopped at primary level education. This could be explained by people who get minimal education attainment, who get minimal level of education, usually tend to retain more of their traditional knowledge, unlike the people who progress to higher level of education. Usually people who progress to higher level of education tend to accept the Western culture and trust the traditional culture. Which one is the question? Before these conditions have been there, even before the white man came to Africa, how did these people treat these conditions? So, do we need more research in traditional medicine so that we can bridge the gap about scientific evidence? So, coming to the knowledge and awareness of medicine, or TMPs about uterine fibroids, most of them attested that uterine fibroids are common amongst their patients. They define them as swellings that invade the uterus, and most of their clinical descriptions and features they provided were similar to what is in literature. Also, they used scan for diagnosis before treatment, which suggests that they interpret conventional medicine to conventional approaches of diagnosing before treatment. So in the study, we identified 47 plants belonging to 32 families and 45 genera. And Fabaceae had the highest plant species, as seen in this infographic. So the table was arranged as follows. The botanical name, like you see, Osmanum sinoatum. Family name, like you see, Polygonaceae. The local name, which is like Cafumita vagenda. The method of preparation, the administration mode, the dosage, the growth form, the part which is used, and the plant source. And also other additives that usually which are not plants, like you see in this charcoal. And then this aspect of frequency of citation, relative frequency of citation, and sedenity level, this way I can show the level of importance of these plants. Just the number of traditional medicine practitioners who talk about these plants, that they use them to verify those. And that's what we use to select our age plants for phytochemical screening. Exactly. So leaves were the most commonly used plant parts, and most herbal medicine were taken orally. And as you see in this infographic, most plant forms were herbal, followed by trees, followed by shrubs, and most of these medicines were gotten from bush, followed by gardens, followed by forests. And as you see in phytochemical screening, we identify the presence of phytochemicals which have the potential of being transferred in the 8 selected plants. So in conclusion, traditional medicine practitioners have the basic knowledge about sugar environments, based on the risk factors and symptoms as provided by the literature, and they also value the conventional means of diagnosis of these plants. Then also, we shouldn't undermine the power of these plants, because usually most anti-cancer, as you see, most anti-cancer, like they've been christened, they've been blasting, because of biotoxins, most of them are being gotten from plants. So we should value the plants in drug discovery. So in recommendation, we recommend further studies, that is in vitro, in vivo studies, to confirm the therapeutic efficacy of these plants. And also, authorities should prioritize the conservation of wild plant sources, since most of these plants are being gotten from bush.
Thank you, Brother Carlton. The example data. There's a word that attracted my attention. They say caffeinated, that haven't dragged into non-provider. And they will explain to our colleagues who are from great parts of Africa. Ladies and gentlemen, we are getting further with our presentation, and we just want to make an announcement. If you're here and you have a paper to present, please report to the Secretary desk. If you're here, you have a paper to present, kindly report to the Secretary desk so that you can share with you. And that said, we've so far had Dr. Jeep and Carlton present, and I would want to take this opportunity to probably subject them to questions as those who are already in and already present those who have themselves. So, Dr. Jeep, I would request that you get up here. Carlton, please feel free. Carlton, please report up here for a panel discussion after this. Thank you. Colleagues, I believe you will be capturing questions and areas that have been presented. I also liked the aspect of biochemical biomarkers, and I noted that we have to mind what we do, because we talk about cholesterol and many other things. But also noted that Dr. Mudi probably has some training in nutritional biochemistry, because when he was talking, there was a lot of nutritional component. And Dr. Mudi was sitting right there. I will ask you a question, one sort to do with the hematological biomarkers. You talked about nutritional deficiencies as being one of the factors that contributes to lower hematological biomarkers. In that regard, you tell us what were those nutritional indicators or nutritional substances that you earmarked to be the cause of your hematological illness in the study. And my brother accountant, the phytochemical thing is very interesting. And you notice that colleagues, you agree with me. In the ancient days, our fathers, the grandfathers would just go to the bush and make something, And also in the conventional science and medicine we are told to drugs come from these herbs. Yes, from a political perspective. So we believe these phytochemical components that you get in our medicines just a nice thing for us to trace back to the roots. And I am very happy and excited that this is coming out. So ladies and gentlemen, it's now an opportunity for us to raise questions. I want to request somebody to stand in line. You have another paper?
Yes.
Okay. I push them to sit there so that they ask them questions. But they have this paper. So you remain seated there. Feel at home. Can someone bring Carlton's cup of tea? The neighbor, help us and bring his tea right up here. So we have next presentation from Cheyune, Ronald, and the Mansi, Peter. I met his brother yesterday, and he was telling me he was just winding up with his degree in Makerere. And see everything. This is love. Let's clap for him. Being a student and you're really charged to present papers. So thank you so much. So he's going to present for us integrating HPV screening into HIV and organic science. You're welcome. Okay.
Okay, allow me to take this opportunity to thank the organizing committee, that is the Ministry of Health, for this African Test and Treat Initiative Conference that is bringing us at the center in eliminating cancers and other NCDCs. I recognize the presence of the different delegates, secretariats, policymakers, and other individuals in this conference. So my name is Kamanzi Peter. I'm a student, a finalist at Makerere University. I'm pursuing a degree in biomedical laboratory technology, and I'm finalizing it because graduation is next year. And currently, conducting a research in in HIV patients, how the usage of those antiretroviral therapies, the ARVs, bring about diabetes mellitus. So that is what I'm conducting in Ruaga division. So today we're talking about integrating HPV screening into HIV and reproductive health. So we've been having very many presenters. That is presentation. So we've been having very many presenters talking about cervical cancer and HPV since this conference started. And today I'm also adding a stepping step in cervical cancer in Africa at large. So we know it's very well that this is the leading cause of deaths in women, and about like in Uganda and Africa at large. So statistically, Uganda has a population of 46 million people. That is according to the Uganda Bureau of Statistics report 2024 of the National Population and Housing Census. But of these 46 million, 23 are women, and of which 60% are 15 years and above. These are sexually active and they are at a risk of having cervical cancer. So currently, that is according to the paper published by ICO, the Catalan Institute of Oncology, the prevalence rate is 3.6, meaning that about 4 out of 100, in every 100 women, 4 are at risk of having cervical cancer. And according to this paper, 6,959 are diagnosed with cervical cancer, that is annually, and of which 4,607 die. So that is how cervical cancer is affecting us in Uganda. We're having a lot of deaths, and this paper was in 2023. It was published in 2023, and we've been having, we are having very many deaths. Our women, mothers are dying because of cervical cancer. And when we talk about this, as our former presenters have been presenting, like we had a presenter from the Uganda Cancer Institute presenting that about a third of Cancer Institute is filled by these patients of cervical cancer. Yet it is, we have everything necessary to eliminate it, to terminate it. We have the vaccines, we have the treatment, we have everything, but it is a bit sad that we have such depth in cervical cancer, yes, in Uganda. So, what is our desire? Our desire as Uganda and Africa at large is to have the 70-90 strategy that is in line with the World Health Organization, and our aim is like the 90% of girls are vaccinated, that is by the age of 15, and 70% that is between the age of 35 and 45 are screened, and 90% receive treatment. So, what has been done, recent progress in Uganda, HPV vaccination launch was in 2015, and this launch, it was launched in 2015, but then we didn't reach the full target, that is the 90, 70, and 90. So that means the Ministry of Health, in partnership with PAPFA, that is the United States President Emergency Plan for AIDS and Global Funds and Child Clinton Health Access Initiative. These partners, along with the Ministry of Health, there was a campaign about 280,000 screenings were done, which improved the treatment uptake, which raised it from 0% to 84%, which is near the good target. So this has been a progress in Uganda, because in 2020 we had 1% integration of HIV and HPV in Uganda. But currently, the Ministry of Health is advocating for integration, and it is the way to go. And not only integrating it in HIV Act clinics, but all the healthy facilities at all health centers. This will improve it. So according to the pathophysiology, how it affects, we know it very well that when someone acquires this virus, for a normal human body, it has to clear it using this CD8 cells, the cytotoxic cells. So unfortunately, if the body fails to clear it, there is this virus, as you see there, is incorporated into the human cell. Those are the cells which causes production of oncoproteins. So this protein, that is the E6, and this is those are oncoproteins that have effect P55, that is the tumor suppressor cells that will prevent further failure of apoptosis. So when this one when this C6 and this suppress this suppress the tumor suppressor genes, P55 and the PRP, it will bring about the multiplication and accumulation of these cancer, pre-cancer cells. So that is so what is the perspective? The perspective is that early detection prevents HPV. That is when we do screening and we detect these precancerous lesions. And the best practice is us integrating HIV and HPV, because these HIV patients have a compromised immunity and they are at a high risk of acquiring these cancers. So integration saves life. Yes, that is true, and it is clinical based. HPV screening in HIV. So we have some this practice is being practiced not only in Uganda but Africa at large, and we have the real world success in this integration. And we look at Rwanda, this practice. These strategies have been practiced and at health center level, whereby HPV is being integrated with other health services, not only HIV but other health services, other like service provision sectors. So this brought about this brought about the 1970-90 intervention by the World Health Organization, whereby they attained the screenings and HPV vaccination of the 1970-90. So this practice is also done in Kenya, whereby in Kenya they are integrating HPV and HIV, whereby they are also advocating for massive screening, where they do community outreach, and it is they offer massive screening and national HPV programs. So this has been done in Kenya, and also in US, that is the world at large, the developed countries, because right now we're talking about the low and middle income countries. So this has been done, and in USA it has been a success. This, whereby we are having the PAPFA, that is the United States President Emergency Plan for AIDS. This has been a success in the developed countries. Now, what are the intervention gaps? In Africa, 20% of HIV clinics in low-income and developed countries offer HPV screening. Yes, due to costs. So it is still low in Africa. The integration is still low in the HIV clinics in health centers, and unequal access to HPV screening is also a problem, that is not in the intervention blocks. Then low fundings. So what to do? We should advocate for government fundings and low costs at HPV tests, that is in Africa, because in Uganda at Cancer Institute, HPV test is freest. Then screening and vaccination should be done at clinics and the other service centers. Then we should also demand for integration and awareness. People should know the burden we have, the depths we have of HIV and of HPV. Then policymakers should set guidelines and practical policies. Then for clinics, training health workers on HPV HIV integration will improve screening rate by 50%. Then, for patients who have recovered, we should give our stories to encourage others that things are possible. So the takeaway, integrating this HPV and HIV care is not a lifestyle, it is a lifesaver. Because our ladies are really having this burden of HPV. Now, according to researchers and the other advocates of HPV, or these people coming together to reduce the burden of cervical cancer, we should take it that whenever we bring out these methods of eliminating cervical cancer, we shouldn't stop here. We should go at ground level and implement them. That's when we shall kick off this burden of cervical cancer, because it is one of the cancers that we can eliminate in Africa and we can at large. Because we have everything, we have vaccines, we have treatment, we can screen and do everything in eliminating cervical cancer. Then, we should also think about the carriers which are being made, because it is mostly transmitted via sexual intercourse and what. So we should think about how to control, like, the researchers think we should think about on how to control its transmission in men. I don't know, that can be a good research to think of, so we can eliminate.
Dear President, thank you. All right, thank you. Come and let's clap for him. Thank you. As an upcoming researcher and scientist, that's lovely. It's a nice paper. HIV and cancer screen. That's interesting and indeed nice. That resonates with the vision of Ministry of Health in Uganda, that is interested in having integrated and innovative, inclusive healthcare system. So indeed, we appreciate that. Friends, we are running against time, and we want to ensure that we finish this very fast. We have a few more presenters, I think one or two. So when you come up here, be straight to the point, okay? Hopefully you should spend a little time in the preliminary pages, but give us the results so that we can save time. The next person here I have with me, are you from Nexus? Are you here? Yeah, please come forward. And I'm giving you exactly 5.35 seconds to report. Then 6 minutes to present. Okay, let's listen to Ayub from Nexus Center and tell us what Nexus Center is. Okay.
Good morning to you all.
Erican.
I acknowledge the elders under this roof and also pay respect to your contribution to our society. Michael Hussein is my name. I'm an epidemiologist with a Master's in Epidemiology from Adekunle University, and I'm a PhD student still in the same field. I hold a Bachelor's in Nursing and also have an advanced diploma in health service management. I am the CEO of the Texas Center for Research and Innovation, and I'm here to
After this, about this guy.
I've talked about that. I'm a dedicated community nursing officer and manager. I'm really enthusiastic about evidence-based research, and I'm the second born to Mutuzo Aisha. We are empowering women, and my research interest is in occupational health, communicable and communicable diseases, and more emphasis on implementation science. I'm a trainer, I'm an entrepreneur, and I'm the CEO of Nexus Center for Research, a registered research company that is research and innovations. So for today, my theme, apart from the theme of this event, which is United Unique, but now for me I'll put United Unique Actions. What have we done in your facilities and what next? That is probably the thing that I'm going to write on. Briefly, what have we done? As Nexus Center for Research and Innovation, I don't know whether Uganda Cancer Institute is around. I am an expert in One Health. I've written and published a book in One Health based application. So from an informed mind, we prepared the One Health framework for cancer management. And I don't know whether I presented on the same platform at Uganda Cancer Institute and presented to them a draft of that kind. This works, and really looking forward to cancer management. We can never, I scientifically prophesy that we shall never manage cancer of whichever type without multi-sectoral collaboration. We shall scientifically prophesy never handle. So this is really applicable and proven. I did a study with Professor Robert Basaza, and this was to understand how traffic police officers work with public health officers when it comes to pre-crash, crash, and post-crash. It was surprising. I reviewed the policy, the road safety and traffic policy, and it wasn't resonating very well with the public health policy. It simply shows that they are working in silos. When we had a one-on-one interview with the commissioners, that is what they said. We last worked with these bodies during COVID-19. That is the statement that was made. However, I'm trying to bring to your notice that if a crash happens on that road right there, the first person to come is a police officer with a gun. Does it rescue? How is the person that the casualty rescued in that situation? You will hear situations like the police officer saying, "It is from the road traffic accident that my status turned positive HIV." This can be an officer or can be a casualty. Okay? My thinking or my approach is let us apply One Health approach. Let the police officer, as he goes to the scene, to secure the scene, let him go with the doctor, let him carry gloves, let him carry appropriate PPE to rescue the casualty and also to rescue himself. That is the approach, and that is the One Health approach. Away from this, no progress. Thank you. So what else have we done? It's something to develop a guide, a diabetic guide and an NCD that pictorially shows the user on how to manage diabetes. This is simply because diabetic patients usually have information from so many, even the clinicians, they give different information. You shouldn't eat that. So a guide that could just pictorially show that. Those are some of the things we've done. We've written a book, we've published papers, and I acknowledge Professor Kusu Andoma, I acknowledge Professor Green, Adam Smith of Kusitama University, and also Dr. Said of IU. But for today's topic, this is what I want us to focus on. For those who are 4 decades in terms of age, you can look at the image and know who that person is. To give you a background, in 2022, in 2020, if you see the other image, I don't know whether you can see it clearly, it has a date, it has a location. Those were 2 interns right there. And this is what happened. Within that day, those interns stepped on that ward. Okay? Managing a first COVID patient under that unit, that facility down there. These interns, following up that management and stabilization of the patient, when all the healthcare workers had actually had run out of these suspected COVID patients. In the earliest morning, when the consultants reached after these two interns stabilized that patient, these interns, nobody talked about them. Okay? Scenarios such happen. That is traumatizing. In 2022, when I embarked on the journey to improve my career, I was working at Kusitema University. I was pursuing a diploma and I had started my master's. It was just out of curiosity that I didn't know that I was actually driving myself to the destination of death. Burnout really struck. I remember one time in the morning, I woke up and I couldn't feel the strings that hold me on the ground. I fell into the dressing mirror. When I went for medical treatment, they gave me calcium and adrenaline. I realized that in the journey to achieve my goals, I was actually losing myself and self-care. Losing care even for those that I love. The other month after that episode, my son got peptic ulcer, and when I took him to the hospital, he actually told the doctor, "Is it okay that I can share this medication with my dad?" The doctor asked him why. "Okay, you prescribe for him, you give him medicine that can make him sleep. My dad does not sleep." The situation that I'm talking about is the situation healthcare workers are going through. They are overwhelmed, burnout, emotionally distressed, psychologically distressed, and these things don't matter. If we don't care about healthcare workers, who will care about us and those that we love? The image you're seeing right there is for a very renowned and celebrated doctor who is currently, I think, 25 years under his grave. He's called Dr. Matthew Lukwia. He's celebrated every year in Uganda. Dr. Matthew Lukwia died from Ebola in 2000. And on his deathbed, this is what he said: "This disease is going to kill me." That was Ebola. "But let it never kill any healthcare professional." And this is what I'm up to right now, and the gist of my presentation. The image right there, the gentleman, the interns that I'm talking about, I'm the photographer and I'm the one sleeping next to also an intern. I published this paper, that was my first publication, trying to bring to notice that the safety of healthcare workers is very for patient safety. If we don't care about healthcare workers, where I'm also part, we don't have patient safety at all. So what are we going to do and what next? I bring to you a survey that I'm currently running online, which is a survey that I am very well hopeful that it will work for healthcare workers and even those who really think, those who are achievers. So this survey, currently right now, I'm having 96.7 healthcare workers reporting that they're emotionally distressed during duty. This actually, the supporting mechanisms are not available. That is also reported. Those blue curves there that you see is not available. And even those services, those facilities that have available services, these support services are inactive, are ineffective. This is the situation that we are talking about. And what are we up to? We are up to a code lavender. A code lavender, which right now I think is the way to go, is a peer support program for carers who have experienced traumatic events. Let me give you the very best example. The other night that I slept caring for a COVID patient without knowledge. They had not trained me donning a doffy, but I had just knowledge from videos on how to don a doff. They had actually sent me to a den of death as an intern. The only thing that I needed the next morning was, thank you. It will work better next day. And well done for stabilizing the patient. That will definitely work the next day. But I tell you the fact, we never reported back to that unit for a full month because of that trauma that we went through. So a code lavender only calls for that. How are you? How was your night of work? Can I offer you a cup of tea? Okay. Only that would work. Leaders and directors of hospitals can actually finance this. They can finance a cup of tea, they can finance some good shelter in these facilities where people can have a rest. But as reported, they are not available. So a code lavender enables recovery from the traumatic stress of care delivery, and also lowers anxiety and depression and traumatic stress syndrome, and significantly impacts on self-care and the care of the patients. The images you can see there is a simple pictorial illustration of the code lavender. You can imagine in theater where after your operation, your fellow colleagues congratulate you for the success of the operation. You can imagine calling your friends at home and then they comfort you in sorrowful moments. Having a dance at the facility and maybe sharing, even if you cry it out to the body and then seek assistance. Then also trainings. That is what a code lavender is all about. On the side of Nexus Center on the banner, I have codes, a QR code that I've been sharing with you. So I encourage you and empower you to scan the code, participate in this study, and then you shall reach out to the facility to Robin for your code lavender. So what's next? So without One Health, without use of AI, I don't think we are going nowhere. So my suggestion right now as CEO Nexus, and also I think is my last slide, let us use a One Health approach. In whatever you say, you want to implement HPV, you want to do vaccination, the people you're talking about stay much time at schools. Why don't we integrate vaccination with curriculum? Why don't we see that students are very important to school, they come with a card of vaccination. That this girl has been vaccinated. Before you enter, before you have to show the card. Very simple and clear. And then you achieve the reality. So some of the things are very practical, and I actually don't support any person who will stand here and tell me policy issue. I definitely have a feeling that practice can precede policy. You've seen what has happened with prom. Prom has been cancelled from schools here in Uganda, but it has been a practice. People have been doing proms. So the practice has informed the policy. In your capacity as facilities, you have the capacity to even go to school and you tell them, like a heart institute, like a cancer institute, a small paper can be got into these schools. A small paper can go to NBS, can go to NTV from another artist, and you have advertisement for free. But we are doing this and we think we can work in silos. If we are still continuing to work in silos, there is no work in progress. Let us embrace the One Health approach. Scaling up a code lavender, if there is no healthcare work, emotional support, psychological support, don't expect your loved ones to be healthy. Them, no and never. You will always keep taking your clients, your patients, your loved ones to cancer institutes, and you will be picking out bodies. I scientifically prophesy that. Practice precedes policy. I've said that. Let us use appropriate technology and let us use appropriate AI. I use AI, okay? And during my work, I've proven it right that I'm using AI professionally. I've published so many papers. I've presented one in the US, in Britain, and they have 3.3% plagiarism. It simply shows you that I'm doing very well with AI. 3%. One of the professors actually wowed, was so much wowed how I present papers that have very little plagiarism. So that means I own the work. But I'm using AI, I'm just saying that I'm using AI. So the other thing is NICRI partnership. Let us partner with these organizations. Partner with us. Call us to your facilities. Let us design for you a code lavender. Let us design for you 2 places where your staff can have some emotional distressing comfort zones. Call us. Let us do research with you. Let us do surveys with you. It doesn't need reg approvals. These are just quality improvement projects that don't need reg approvals. Call us. Let us help you in these things. Very easy. Partnership. If you can partner with us, partner with any organization that you feel can properly work with. Let the ministry partner with private entities. Let me give you one example. We have only 4 cardiac catheterization laboratories in Uganda. 4. And I think one could be the regional referral at Houston. And the rest are in private use. And you expect the 4 to sell 4.8 million without partnership, private-public partnership? This is what I'm talking about. The One Health approach. Without multi-sector, we have no health in Uganda. I'm telling you that I scientifically prophesy that. Thank you so much for listening. I apologize for those that I may have with my verbal language. I hope you forgive me. Mangayu Hussein is my name. I'm an epidemiologist and I'm the CEO of Nexus Center for Research and Innovation. I'll be seated right there for the whole of this day. In case you need any information in the partnerships readily available. We do research development, we do research training. Is that adequate enough? Or very adequate enough?
You have, but we may ask you to pay more some fee to do further advance. But ladies and gentlemen, let's appreciate Dr. Ayu. Thank you. See them sit up there. We don't want to call you back again. Our brother, please come. This thing has touched me. Very, very interesting. One health care providers, environment, and industry. We should all play a big role in ensuring that we contain this, uncertainties. The code lavender, very interesting. Yesterday I saw some barcode, on tables. I didn't know what it meant. Hopefully, yesterday, if you had presented this to many people, they have taken note of this. Ladies and gentlemen, as he has just presented, I would wish us to proceed to questions before we hear from Madam Annette, now the chair of the scientific committee in this Africa Test and Treat initiative. But allow me also to recognize Dr. Kalunji. Let's clap for Dr. Kalunji. He's in the house. If you don't know him, let me request him to stand up for recognition. That is Dr. Kalunji. Dr. Kalunji taught me pathology when I was doing my degree in laboratory science in Monaco, Annapurna University. And I recognize the presence. Thank you. So, ladies and gentlemen, let's welcome Madam Annette. Africa Test and Treat Initiative has strongly come into play under the leadership of Madam Annette as the program coordinator in Ministry of Health. And she's such a passionate professional. And we cherish you, Madam. We're proud of you. She's an icon in the healthcare industry, and I believe all of us appreciate that. She recently whispered to me that we should usher this program to the nearest country now. just across here. That is Kenya to host next year. And in that regard, with us we had the president of Monso. He's with us, and later on there's a session we're going to hold that do so much with how we can collaborate going forward. But that said, thank you for bringing Zimbabwe on board. Let's clap for Zimbabwe again. Over to you, madam. And the presenters, be patient, stay there. We are going for Q&A session after Madam Annette. Thank you.
Thank you very much, Session Chair. All protocol observed. I want to thank all of you for the great work well done. And allow me to thank all of you for the special inputs. I want to say I'm very happy that for the past 3 years, this conference has brought out the exact list of the Africa Taste and Treat initiatives. Let us clap for all of us. Before I begin my presentation, I want to give you just a brief overview. Ayubu has really tackled the most painful area. This conference is here to prevent. We don't want to lose anyone, starting from you, me, our children, and everyone. All lives matter. So under this theme of United by Unique and placing people at the center of care, we are really humbled because this has been our strategy since the initiation. So when the entire globe took it up, and we are going to run it for the next 3 years, it's a global theme for elimination of cancers. Not forgetting that many of the diseases which we are handling in early stages and we mismanage are ending up, people are dying of the late stage cancers due to the poor attitude and practices in the start. For example, when you look at hepatitis B, I've not got that abstract. I don't know, but I think hepatitis B triggered us to start this. Many people wake up when they have reached in the hepatocellular carcinoma stage, which is so painful, and yet a virus can be controlled by only vaccination once you detected negative, and will be able to prevent you from reaching to the advanced stage. Actually, that disease is what brought together. I want to appreciate the pathologists in Uganda. In 2016, that's where we picked. It was a very simple thing, but we had a lot of barriers, just like you see what is in HPV. And as we speak now, I think the barriers are too many. It is now beyond. Multi-sexual collaborations are very key. As we speak now, last week we just lost our colleague on the National Organizing Committee to a terrible accident. That's Dr. Arthur Ahimisiwe, who was supposed to be with us here. Dr. Arthur Ahimisiwe was saving a border man. As he was riding, he wanted to save a border man. You know, once a doctor gave a what? That's in Chiando. And his motorbike just went off the what? He died terribly To be sincere, we always, a lot of gaps were in, but our colleague died painfully in Chiyandongo Hospital. The surgeons did whatever they could, but we couldn't save our own. An accident. Just in our leisure time, I can drive a motor ride up to Lira because I'm a human being, I'm a doctor. So multi-sectoral collaborations are very important. So Ayubo's presentation has scratched my heart. We cannot wait. We are calling upon all of you to join us. All of you are unique. Are we together? Each one of us is. You cannot be like me and I can't be like you. That much you can do is going to save all of us. Are we together? So that is the reason why you see me here. So right now, before we continue, I want us to first observe a moment of silence. And we'll be able to remember all our colleagues. We've lost very many people. I think even by now, Dr. Wamala would have been here with us, but we lost him. We've lost very many. We lost our lead in capacity building to leukemia in the lab department still this year. So let us observe a moment of silence for all our colleagues who have left us. May their soul rest in peace. Amen. So that is the exact gist of the conference. We have a lot we can do. You have a lot you can do. For me, I can do the little. So as you see me very passionate, I'm doing this in memory of my parents, whom I lost to HIV in 1996 when I was just 11 years, and my mom in 1997 because of poor management. A lot of gaps were there, which all of them we've presented. But can we wait to lose others? As a child in that time, my dad left me having told me to become a doctor. I wanted to be a bank manager. He was a bank manager. I loved that. I wanted to be like him. But when it came to my people, he sat us down and told us, my children, your generation jobs for bank managers might not be there. I want all of you to study and become doctors. That is the NHC here. And I'm very proud to be working in the Ministry of Health. I want to thank all of you across the globe who have embraced me, and we are pushing the agenda to save lives. My first passion, I don't want children to suffer the way I suffered. We are here, but many of you don't think about your kids. You ask me what those kids go through. As you are not minding about that health worker, your observations are so critical. When we are looking at the ISO, I'm a lead implementer in ISO 900. I want to thank our commissioner who has done her best. So as we are leading this conference and is in Africa and the programs at Ministry of Health, we are using high quality management standards. So we and we are much ready to save lives by hook or crook. So we don't want to lose anyone. We need you, your children need you, Uganda needs you, Africa needs you. This is the reason how we are going to make it. So at the same time, allow me appreciate all of you. I think this year's conference was almost being postponed because we didn't have resources. Previously, we've been getting some support from PEPFAR, but due to Trump's order, the budgets are too tight. And that's why you don't see any IP in the house. So Tekla, we apologize for what you saw, but we wanted the best more than what you are thinking. But allow me appreciate all the individuals who facilitated themselves, because you did a great job. We did convene for people who sponsor themselves. A special way we love for our sponsors, the exhibitors. Let us clap for them. I remember by last week we had to reach to them, and many of them did their best. And all of you who were sponsored, we used those little resources from our exhibitors. And we had to look through the registration list, but the priority went to, this is more of an implementation conference. We had to set an implementation, and we begin drawing implementation action plans. And that is the core reason why we've been here up to date. We are excited that we have gotten the best outputs ever. So our dear consultants, people, let us clap for our consultants.